Hello and welcome to the Clinical Management of Torticollis and Plagiocephaly. This lecture content is divided into two primary areas. The first aspect will address management issues related to children with torticollis, and the second part of the lecture will deal with management of the child with plagiocephaly. Both parts of the lecture will move through the elements of PT practice from examination through intervention. Although this lecture covers two different diagnoses, these conditions can often be seen together and therefore have some overlapping characteristics. I have grouped the learning objectives for both torticollis and plagiocephalus together as it relates to moving through the elements of PT practice from examination through intervention. It's important to note that at this time, clinical practice guidelines do exist for the patient with torticollis. They do not currently exist for children with plagiocephaly. So information presented as it relates to that condition is really through use of best evidence and clinical experience in this area. By the end of this lecture, you should demonstrate an understanding of the etiology and the pathophysiology behind both torticollis and plagiocephaly through your application of previous coursework and your clinical medicine notes and materials. You will be able to discuss the role of the physical therapist in prevention and early referral for both torticollis and plagiocephaly. We will use written case studies and videos to discuss the impact of torticollis and plagiocephaly on movement disorder and what you may expect upon examination. We will use clinical practice guidelines and/or best evidence to talk about examination procedures, select tests and measures for evaluation for both of these conditions. You will be able to identify impairments in body and structures, activity limitations, and participation restrictions for children with torticollis and plagiocephaly. And from there, you'll be able to then identify what these children may have from a needs perspective and what their potential prognosis is for both torticollis and plagiocephaly. Lastly, using clinical practice guidelines and the best evidence, you will be able to describe appropriate intervention strategies, not only from a procedural perspective, so our hands-on interventions, but what is required from a patient and family education, and additionally recommendations for orthotics or adaptive types of equipment. Readings and resources for the content on torticollis and plagiocephaly would come from Chapter 9 in your Campbell's text. That chapter deals with both congenital muscular torticollis as well as plagiocephaly. And then the clinical practice guidelines that have been developed for the torticollis related content, they were originally developed in 2013, but an update was published in 2018 that would be an appropriate reference as you look to pull this content together. Next, we'll move into the content related to torticollis. We aren't going to spend any time reviewing the etiology or the pathophysiology behind CMT because you have that information in your Clin Med notes. Just recognize that congenital muscular torticollis can develop for a variety of reasons and can be attributed to occurrences happening prenatally before the child is born, during birth, or postnatally. By definition, CMT is a unilateral shortening or fibrosis of the sternocleidomastoid muscle group. As such, torticollis will present as a postural deviation from midline consistent with lateral flexion to the side of the involved SCM muscle group. Oftentimes, it's also combined with rotation away from that side. For example, if a child has a left-sided torticollis, you could expect that child to be laterally flexed to the left and rotated towards the right. There are three primary types of CMT that we'll discuss, and they're listed there from their most mild to most severe form. The first is postural CMT. Essentially, this involves a positional preference of the child so that their head is out of midline into lateral flexion to the one side. but there's no passive range of motions restrictions for this child. So they have full range of motion from a passive perspective. They just prefer to have their head off to one particular side. Muscular CMT does present with unilateral tightness of the sternocleidomastoid into lateral flexion or rotation, but there's no mass associated with it. So you can't feel anything on palpation, and on imaging, there would be no fibrosis of that tissue. SCM mass torticollis is different in that not only are the range of motion restrictions present, but that child does have a palpable nodule or a fibrosis band. So that would be the most severe form of congenital muscular torticollis. The clinical practice guidelines for children with torticollis suggest that torticollis can be prevented through early education, early screening, and referral as needed. From an education perspective, this would consist of early initiated supervised tummy time, at least 3 times a day. So this would be tummy time that is starting within the first couple of days of life. That is not consistently what happens when individuals have children. Usually the education provided to those families relate to keeping the baby off of their stomach, especially while sleeping because of sudden infant death syndrome. But really what needs to happen is we need to switch gears a bit and focus on early tummy time within the first few days. If you wait until what a lot of pediatricians would recommend, which would be like 4 or 5 weeks or at that 1 month well visit, if you wait until then to start tummy time, you're often going to find a lot of resistance to being in that position from the infant. So early initiated tummy time, 3 times a day would work best. And tummy time can really look like a variety of things. It does not have to be just flat on the ground on your stomach. You can see in the pictures here that with the caregiver reclined to some extent, if they're laying on their caregiver's stomach and chest, that's still tummy time. It's just perhaps not completely horizontal with the ground, and that's okay. The point is we're taking pressure off the head and allowing full active range of motion, which is likely to then decrease the chance of developing torticollis. It's also going to assist in developing patient preferences to one side if you're changing that child's position frequently. And you can also prevent postural preferences by doing a lot of positioning throughout the home, throughout the day. So that could relate to how the child is sleeping at night, alternating which side of the crib you put them on, alternating which side you feed them with if the baby is bottle fed early on. So there are a variety of environmental aspects that you can change up to help prevent torticollis from developing. And then the role of the PT in this setting is to really try to reach those physicians, pediatricians, to encourage them to promote this early prone positioning instead of waiting until perhaps that 1 month period of time. And we also want to try to reach staff in the hospitals, so nursing staff who are educating new mothers about avoiding prone. We really want to try to initiate dialogue with them to let them know that prone is okay as long as it's supervised while the child is awake. So some early education pieces that the physical therapist could initiate can go a very long way in the prevention of torticollis. Another strategy that the clinical practice guidelines suggest that physical therapists should be involved with as it relates to early detection or prevention of torticollis is with screening. So physical therapists are in a good position to be able to screen the newborn child within the first couple days of life to be able to look for any sort of facial or neck asymmetry. Beyond the observation, the physical therapist is also able to assess range of motion, and you're really looking for that newborn to have at least 100 degrees of cervical rotation to either direction and enough lateral flexion such that the ear can closely approximate the shoulder. Beyond the screening, this also provides an opportunity to educate new mothers and to educate caregivers about what they should continue screening for as it relates to asymmetries, and then they can carry that out on a regular basis. The 1-month well visit then should also include a screen based on those same factors. So again, looking for, is there any developing asymmetries in the face, in the neck, and what is the passive range of motion related to rotation and lateral flexion. If the results of any of this early screening should flag as a concern in that we find that there is a range of motion restriction to one direction and or that there are visual asymmetries present in the face, then we should be prepared to make a referral back to the physician, and that child should be referred for a physical therapy full evaluation as opposed to just a screen. The research is very conclusive that early intervention leads to a shorter episode of care with earlier resolution of symptoms. So able to correct the position of the neck, gain the range of motion back if that has been lost, and really be able to improve that child's quality of life. Certainly there's a financial incentive because the earlier you start, the less medical intervention in theory that child's going to need. And the research also is fairly conclusive that with physical therapy initiated before the age of 3 to 4 months, those outcomes will be greatest in that they're going to have that shorter episode of care with the earlier correction and less likely to then go on and need surgical intervention. One way that the physical therapist can talk to the physician about their need for physical therapy, the child's need for physical therapy, is to be able to provide them with and share the results of the 2018 update to the muscular torticollis clinical practice guidelines. So sharing in that evidence with other practitioners, physicians, parents, and really being an advocate for these children to receive early therapy will go a long way. This flow diagram was taken from the clinical practice guidelines for torticollis, and it basically outlines the possible referral and communication pathways that we talked about on the previous slide. So if you look over to the left, the flow diagram is broken up into two distinct time periods: birth to 2 days, so that would be the newborn period where the child is in the hospital and they're in close contact with a variety of medical professionals who would be capable of screening the child for torticollis. Then below that is the time period after 2 days and onward, once the child has been discharged home to the care of their parents. And at that point, that screening might be mostly up to the parents at that point because they're the ones that are going to spend the majority of the time with the child, and then potentially the physician as well as it relates to the well visit. So the key is to really give the parent the education early on for the screening so that they can continue with that screen. And then if the child screens positive or any of those areas are flagged as it relates to the asymmetries or the range of motion, then it would be appropriate to make referrals to the physical therapist, or if there's any visual impairment, making sure that the child is referred appropriately. Any neuro-based impairments to be followed up with neurology. So it's important to kind of look through and follow this algorithm so that these children don't get overlooked. And we know that early referral, again, is going to improve outcomes and decrease the episode of care drastically. So this is really just a pictorial representation of how that flow chart should look and what the procedure is to move through that. Once the infant is referred to physical therapy, An examination will be conducted. As you know, you'll begin examination with observation of that infant's function. You'll be doing this concurrently as you gain the subjective data from the parent or caregiver. You have a very detailed laundry list of all of the questions that you would ask in a subjective history, and certainly those are relevant, and we would think of those top subjective questions as it relates to the child's typical day, potentially past medical / surgical history or medication based on that child's age, and certainly what are the parent and family goals for that child. Additionally, the clinical practice guidelines have identified these 9 health history factors that would be really important to include as part of the subjective history as it relates to the child with torticollis. Certainly, you'll want to know that child's age, both chronological and correction. The age at the initial visit is really key because that's going to assist with assigning a severity grade, as we'll get on and talk about in the next several slides, and it's going to also drive the prognosis for that individual. Needing to know the age would also be relevant to knowing the gross motor skills that are demonstrated by that particular child and if they are developing typically as it relates to their age-matched peers. You'll want to know the age of onset of the asymmetry. So when did the parents or caregivers or physicians notice the torticollis or the asymmetry present in the child? And that's going to also help with being able to differentiate between acquired torticollis and congenital muscular torticollis, which also will help drive the prognosis as it relates to the plan of care. Additionally, you'll want to ask questions as it relates to the mother's pregnancy as well as the delivery of the child. It's important to know if the mother received prenatal care or if she experienced any challenges during her pregnancy, with a special emphasis on the last trimester and the last aspect of that trimester, so the last several weeks. You'd want to ask the parent if they ever had the sense that the baby was stuck or was having challenges moving, as that might help inform our understanding of the development of torticollis or even moving on to plagiocephaly. You'll want to know what type of delivery the mother had as it relates to either vaginal or C-section, if the child was breached at all and the physicians had trouble getting the child out, as it relates to needing to use forceps or suction to be able to assist in that delivery. We know that congenital muscular torticollis can often occur if the sternocleidomastoid was traumatized or strained during the delivery. So we would want to have information as it relates to that to help us paint the best picture. That it is possible that there's a genetic link component to torticollis, so you'd want to get information pertaining to that. You want to make sure that you get a thorough medical history for this child because there are many conditions across a variety of systems that can lead to asymmetry. So we're really trying to figure out the cause of the asymmetry so that we can direct intervention appropriately. So you really want to make sure that you're asking about any sort of neurological causes of asymmetry, such as brachial plexus injury. Musculoskeletal conditions can certainly cause asymmetry as it relates to clavicle fractures or subluxations of the spine, hip dysplasia, so wanting to check that out as well. Even gastrointestinal conditions such as reflux or hernias can cause the child to position asymmetrically, especially if that individual is in pain. So you really want to get a thorough medical history to determine if there could be potential causes of asymmetry outside of the actual structure of the sternocleidomastoid muscle. And then lastly, of course, we want to ask about developmental milestones. So this would be geared based on the age of the child who is being examined, but you want to have an idea of if the child is developing typically or are they falling behind their age-matched peers. So really, what is the impact of the asymmetry on the developmental milestones from the perspective of the parent and caregiver? Once you've completed your subjective history, you'll move into a systems review where you will screen for non-muscular causes of asymmetry. So outside of SCM involvement, what are some potential other causes? We touched on this briefly in the previous slide, but it's important to note that the research suggests that up to 20% of children and infants who are referred to physical therapy for assessment for torticollis actually have another underlying cause for the asymmetry. So it's really important to be able to kind of tease that out in your differential, and that would begin here with your systems review. So making sure that you do a thorough screening and review of the musculoskeletal, neuromuscular, integumentary, cardiopulmonary, and then other systems such as GI, vision, and hearing to determine if there's any other potential causes of the asymmetry. When thinking about selecting appropriate tests and measures for this individual, you want to make sure that you are examining across all levels of the ICF. So you want to have a really good understanding of what that child's participation is like within their family, and you've probably gotten a lot of that information from the subjective history. So really understanding what the child does throughout the course of the day, how much time they spend in equipment or playing on the floor, especially in prone, would be important to understand moving forward. From an activity level perspective, that's really going to come from your developmental assessment of that child. So what are their motor milestones? How do they tolerate being in prone? You may choose later on to select an appropriate standardized outcome measure that will provide you some objective data at the activity level. But important to think about both participation as well as activity. Moving into the body structures and functions aspect of the ICF, the clinical practice guidelines recommend that at a minimum, the 7 bulleted items listed here are assessed when examining a child with an asymmetry potentially due to torticollis. They're listed here for you in order of what is the most active or what requires the most out of the child to the least active. First, you're going to begin with examining a child's posture and tolerance to a variety of different developmental positions that would be based off of their developmental age and where you would expect them to be functioning. So whether you are placing the child in these developmental positions or they are transitioning in and out of these developmental positions, you really want to make note of what is their posture with specific detail to any asymmetries that might be present, especially along any aspect of the spine, beginning from the cervical spine all the way down through the lumbar and inclusive of the hips. And you also want to note what is their tolerance to these positions, and that's going to then further drive our potential interventions. One of the most important tests that you could measure for this particular group of children would be active and passive range of motion. As you know, we'll begin with active range of motion, and our focus right now will be as it relates to the cervical spine. Taking a look at rotation can be done in supine for a young child under the age of 3 months or sitting on a parent's lap. You should also be looking to examine active range of motion in prone to make sure that the child is able to clear their airway once they're placed in that position. You can take a look at lateral flexion by holding the infant vertically and tipping them from side to side, very much as you would when checking for equilibrium or righting reactions. So taking a look at determining how much lateral flexion they have when tilted side to side. Passive range of motion for both cervical rotation and lateral flexion can be measured using an arthrodial protractor. You can see how that might look as demonstrated to the right in the picture. Approximately, you should expect about 110 degrees of rotation and 70 degrees of lateral flexion in the cervical spine for an infant. Moving on, you'll also want to take a look at the gross range of motion of that child's upper extremity, if there's any pain associated with that, as well as in the trunk and lower extremities. And we've already talked about some of the other conditions that could mimic challenges with torticollis, or that could also be existing concurrently with the torticollis. Examining the integumentary system is also very important as part of this child's examination. You'll want to take a look at the integrity of the skin. Are there any areas of breakdown? Certainly the symmetry or asymmetry of the folds, all the way through the spine and shoulder and hip region. And then you want to make note if there is a presence of a sternocleidomastoid mass, and what the location is and the general size and shape of that mass. You also want to make note of any discoloration of the skin, if it's red or irritated, and if there's any rashes at any section. Although you would have examined for any asymmetries in posture throughout a variety of developmental positions, it's also really important to take a look at any asymmetries that might be present in the craniofacial areas in the shape of the head and skull, as we know that torticollis can also have impact in these areas and lead to plagiocephaly. So we'll pick up this a bit more in the plagiocephaly lecture component, but at a minimum you're going to want to use your palpation skills to examine areas of the anterior and posterior fontanelles, as well as palpating the cranial sutures to assess for any ridging over the sutures, and using your visual skills to document any additional asymmetries in this area. Examining and documenting pain will be an important part of this examination. Although we wouldn't expect an early torticollis to produce too much pain, there could be pain associated with other underlying conditions, hip conditions we've spoken about, fractures, even skin irritation can be quite painful. So we want to not only be able to determine if there's pain, but what is the cause of the pain. Part of that with an infant is really trying to tease out whether they're in pain from some sort of physical related condition, or if it's more of a stranger danger or unwillingness to participate in the examination. So trying to tease those pieces out. You could document pain on a variety of scales that rate facial expression and movement and behavior. So you could think about using any of the VAS scales or specific scales for infants, such as the faces, legs, activity, cry, and consolability scale, which is abbreviated FLACC. That scale will allow you to objectively document your findings. Once you've completed all areas of your examination, as it relates to observation of function, subjective history, review of systems, and gathering of objective data from specific tests and measures, you're going to take all that data and synthesize it as part of your evaluation of this child. With that information, you're going to place that child in a level of severity as recommended by the current clinical practice guidelines. There are 8 grade levels associated with torticollis, and an infant is classified into one of those 8 categories based on the age that they were at the time of the initial examination, so really looking to see when treatment is beginning. Their range of motion as it relates to cervical rotation, specifically the differences between their right and their left side, so trying to pick up on that asymmetry. And then whether or not they have an SCM nodule. So those 3 factors are going to help us as physical therapists prognosticate how long recovery is going to take and intervention is needed, and also the extent of which we can expect that child to regain full motion and full recovery. If you look at the examples below, you can certainly see that grade 1 is the most mild form of CMT, and then grade 8 is the most severe form. You're not responsible to know what is contained within each grade, but you should understand what variables are looked at and a general flow or progression of the grades as they progress. So if you look down below, you can see that grade 1 is a very mild form. The child's quite young, between 0 and 6 months of age, and all they have is postural preference, so they prefer one side, or they do have perhaps some slight range of motion restrictions, but nothing greater than 15 degrees for passive cervical rotation. As the child ages and the range and preference becomes a bit more severe, if you look at grade 8, that's very late, so these are children over a year of age, and they have any sort of asymmetry as it relates to either range of motion or the presence of a SCM mass. So definitely a progression there in severity when looking at going from grade 1 to grade 8. On this slide, we have a pictorial representation of those classification grades and a learning tree or flow chart of sorts as it relates to some of the decision-making process and where we go from here. This was taken from the update to the 2018 Clinical Practice Guidelines, and although it may be challenging to see here on your PowerPoint slide, you do have the reference that you could go to see this in a bit larger scale if you were interested. You can see the classifications grades up on top and all of the variables that feed into those classification scales that we previously talked about. And although the prognosis becomes worse as you move on through those classification scales, it's not quite a linear correlation between those two. So it does get worse, but not in a linear fashion, because there's a lot of other variables that come into play that impact patient outcomes, and you know all about those from the ICF as it relates to some of those contextual factors from both the person and the environment. And if you see that large circle, that oval in the middle there in purple, that really kind of deals with the rest of the story. So thinking about areas such as patient and caregiver knowledge on the challenges with CMT, program adherence, what is the state of the muscle tissue, what is the child's developmental stage, do they have any comorbidities? All of those are going to come into play to impact prognosis. Once the child's been classified and you've thoroughly examined and considered all of those other contextual variables that can play into prognosis, decisions can then be made regarding the intensity and the frequency and the duration of the intervention services to be provided. So although there isn't one specific recommendation based on a level of severity or a grade that's assigned, we do know that there are tendencies to require therapy for a longer duration the higher you are on the classification scale. But regardless of where you are, we know that physical therapy should be initiated as early as possible, and that the frequency of that intervention should be over the course of each and every day, as carried out by not only the physical therapist, but more importantly, the caregivers who are involved with that child and who will be with them every day to promote that carryover. A diagnosis of CMT will be made based off the physical therapy examination data and also after other non-muscular causes of CMT have been ruled out. So that may require referral to another practitioner or back to the physician to rule some of those other areas that we've spoken about out. Once those are ruled out, if the therapist does suspect that, then based off the examination data, a diagnosis of CMT could be made. When thinking about prognosticating outcomes for these children, it's important, as it is with any child, to have well-developed goals that are objective, measurable, and functional, and that include the time in which you would expect them to be achieved by. The prognosis for these children is based on a variety of factors that we've touched on already, such as the age of initiation of treatment, the classification of the severity, how much intervention they get, how many comorbidities or what are their coexisting conditions, and then what is the adherence to the home program like with the family. The data shows us that when a child begins therapy under the age of 3 months old, that you can pretty much expect full resolution of symptoms if the caregivers are on board and carry over the conservative management. So that's really a positive and something to share with the families to help them persist with the treatment that's upcoming. Children who do not receive physical therapy early on, or those who have a more severe grade due to a presence of a SCM nodule, their prognosis without surgical intervention is a bit worse. So you'll see full resolution from a percentage perspective drop as those children begin therapy later, and if they have other comorbidities or presence of nodules in that muscle group. We will now begin discussing intervention strategies for children with torticollis. According to the clinical practice guidelines, the evidence supports that first-line intervention should consist of a multi-pronged approach. We will go on in subsequent slides to discuss intervention that relates to neck passive range of motion, neck active and trunk range of motion, development of gross motor skills and symmetrical movement strategies, environmental considerations and adaptations, and parent and caregiver education. As you might imagine, one of the most important goals for children with torticollis is to improve their passive and active range of motion, especially at their cervical spine. The first grouping of interventions we'll talk about are strategies used to improve passive range of motion of cervical rotation and lateral flexion. This can be done through manual stretching or positioning out of the preferred pattern of lateral flexion with rotation. So a child who has a left torticollis will present with lateral flexion to the left and rotation to the right. So in that instance, you're looking to encourage rotation to the left and lateral flexion to the right, as that would be outside of their preferred pattern. You want to start in a neutral position, and you want to stabilize segments that might compensate for the movement so that you're really isolating the stretch to the SCM. So you can see examples of stabilization below at the anterior superior shoulder region or at the anterior aspect of the chest to really stabilize and isolate the stretch to the sternocleidomastoid. The stretch should not be painful, and the caregiver needs to be aware of that child's signs and symptoms in way of expressing pain and discomfort beyond just crying. So observing facial grimaces, color changes, potentially changes in respiration, all of those nonverbal communication signs the caregiver needs to be educated in prior to beginning a stretching program for their infant. As far as holding the stretch, the child might start to resist out of the stretch, and you want to let them go if that's the case. So these are very small muscles, and we're not looking to strain or injure or cause any trauma to these structures. So a struggling child should be let go, and the resistance should be taken off. Ideally, you'd like to perform these stretches, as you know, anywhere from 30 to 60 seconds with a 45-second average, but that might not be possible given the tolerance of the child. So you can attempt this through a variety of ways, through positioning and also through manual passive stretching. Interventions also need to be developed and established with the caregiver to work towards active range of motion of both the neck and the trunk muscles. So really looking to develop interventions that are geared towards strengthening those weak neck muscles, as well as the diminished strength in the trunk. This can be accomplished through a variety of strategies, such as positioning, handling, and even feeding to target those weak muscles. If you look at the pictures below, you can see through a variety of activities in play that the child is activating actively out of their preferred pattern. This could be done through writing reactions, which you see in the far left picture and the far right picture. So one is through therapeutic equipment, one is through just caregiver handling, where you're asking the child to right their head and neck as a result of being tipped laterally. You could think about feeding adaptations as it relates to which side you present the food source towards. So you would want to offer food from the non-preferred side to encourage that active cervical rotation. Prone play is critical for development and thinking about strengthening of the extensors while elongating those flexors. So really looking to get the child engaged in some midline prone and then rotating outside of their preferred pattern. In addition to providing intervention geared at both passive and active range of motion, therapy should focus on the development of symmetrical movement and symmetrical weight bearing through postures. So you'll want to meet the child wherever they're at from a developmental perspective. So you might choose to encourage midline control in sideline, or if we think about more active weight bearing positions, having midline control in quadruped or in tall kneel or in sitting, and really just meeting that child where they are developmentally and continue to progress them along the developmental sequence, but in a way that is promoting symmetry and really preventing any compensatory movement strategies or any asymmetries that could then pose a problem later on in life when we start to think about contractures and shortening of soft tissue and potentially any orthopedic related issues. So really trying to promote that symmetrical movement through a variety of positions in the developmental sequence. Another extremely important aspect of intervention for the infant with torticollis or some asymmetry is to adapt the environment to afford the child the opportunity to actively move out of their preferred positioning posture. This could be done through a variety of strategies as it relates to placing toys and food sources on the side in which the child does not prefer to rotate towards. So if you think that the left SCM is the affected muscle, that child's going to have rotation then to the right. So putting toys, putting food or objects on the left side of the child on the affected SCM side will encourage rotation out of the tightened position. Additionally, anything that the therapist can do through positioning to promote midline would be a positive as it relates to not furthering contributing towards that asymmetry and that tightness. So thinking about promoting midline in car seats or in swings so that that child is not sinking further into that preferred position. And then certainly using all of those container type devices in moderation. When children spend excessive amounts of time strapped in car seats or swings, it really limits their ability to actively explore their environment and to develop skills that are needed to progress along that developmental trajectory. We want them to be out playing and prone, especially, and really moving around and exploring as opposed to needing to be stationary and not really very active. The last and potentially most critical aspect of intervention for the treatment of torticollis is the education to the parent and caregiver. The physical therapist is only going to be there a short amount of time over the course of the week. The caregiver will spend the majority of the time with the child, so they really need to serve as the physical therapist for the majority of each day. So it's really important to get the parent and caregiver on board with this very early on. You want to encourage the caregiver to really aim for early tummy time, and this should ideally be discussed in the hospital or shortly after the child comes home for any child, but specifically important for children who have developed an asymmetry. So recommendations are up to 60 minutes of prone play or prone tummy time, and it doesn't need to be done in one continuous period of time. So that could be broken up over several opportunities over the course of when that child is awake. As we discussed before, you'll teach the parent passive range of motion exercises to get that SCM lengthened, so lateral flexion and rotation specifically. We talked previously about positioning and handling to promote symmetry, so working in side lying, adapting equipment, having that child positioned in a way that when they're carried, they need to use active extension and lateral flexion outside of the preferred pattern. So a lot of different ways that you can get that active range of motion and passive through positioning and handling. Again, minimizing the time that the child spends in containers. So certainly it's unrealistic to think that a child will never be in a swing or a car seat or some other type of container, but really using those in moderation is the key. So making sure that it's alternated with active time on the floor, in prone, being able to engage and actively explore their environment. And then alternating feedings to each side. So if a child has a preference for a rotation to the right, then we want to make sure that they need to look to the left for their food source and not always presenting the food on the same side. That encourages that further rotation. The next couple slides will deal with intervention strategies that are considered more supplemental in nature for the child with torticollis. So these strategies could be used in conjunction with the previously established first line of defense strategies. And the reason these are supplemental is that the evidence is not quite as strong for these interventions, or there is some conflicting evidence out there. So the studies that examine these supplemental interventions are usually at a bit of a lower rigor or lower quality as opposed to the first line recommendations from the clinical practice guidelines. So for children who aren't responding as well as you had hoped to the traditional first line interventions, you can think about using microcurrent and kinesiology tape. So the microcurrent would be applied directly to the involved SCM, and this is an undetectable current by the child because it's pretty low intensity. And then following that application, you would immediately go to stretching. And the evidence that's out there suggests that children tolerated the stretching better and had improved range of motion into lateral flexion and rotation, which then shortened their episode of care. So microcurrent would be one supplemental option. The other is kinesiology tape. So as you know, this is a stretchy tape that can provide sensory feedback to the child, and the evidence has some mixed results as it relates to this. There is evidence that supports the use of kinesiology tape to the involved sternocleidomastoid, and thinking that that's going to relax that affected side, and then you perform the stretching. There's also some evidence to suggest that taping the uninvolved side can facilitate that muscle group to help pull out of that preferred lateral flexion posture. The evidence is mixed, and some of the evidence suggests that the results that we're seeing and the gains were only short term, and maybe were only effective for while the tape was on or immediately following the kinesiology tape. Additionally, the clinical practice guidelines suggest that there is some emerging evidence for soft tissue mobilization and myokinetic stretching for children with CMT who are not responding to traditional treatments. The evidence that supports the use of soft tissue mobilization was completed in 3 phases, such that the first phase began with passive mobilization, the second was mobilization with stretching, and then the third was mobilization with an active component. The evidence suggests that there was an improvement in passive range of motion for both rotation and lateral flexion after 6 weeks of using soft tissue mobilization. Additionally, myokinetic stretching was also found to demonstrate improved cervical rotation and lateral flexion, as well as reducing the thickness of the involved sternocleidomastoid muscle. This technique involves the use of 1 to 2 fingers over the affected muscle, and the therapist applies an overpressure, and it's usually completed over a long duration, so about 30 minutes. Each overpressure is about 30 seconds in length, and the duration of that intervention would last about 30 minutes. After that, you'd follow with your traditional therapy as it relates to active range of motion and getting the child out of their preferred positioning. There is also some evidence to suggest that use of orthoses for children with torticollis could be considered as a supplemental intervention for those children who aren't responding as we would hope towards the first line of defense. The tubular orthosis for torticollis, otherwise known as the top collar, is pictured over to the right-hand side. This collar could be considered for children who already have established head control, and it's going to limit the motion of lateral flexion into their preferred side. So for the picture here, this child would have a right-sided involvement of their sternocleidomastoid, and this top collar will promote midline and limit somewhat the ability for that child to laterally flex to the right. Additionally, there's some evidence to suggest that use of a soft foam collar also promotes midline positioning, and that's really more through the proprioceptive feedback, because as we know, there's no true way to limit motion through use of a soft collar, but really more of that proprioceptive feedback for midline. And then for children who go on to have surgical intervention because they need that muscle group released, then you'd be thinking about using something like a custom fabricated cervical orthosis that can assist in holding the head in midline. Part of providing intervention to children is being in this continual observation or reassessment of how the child is responding to the intervention. We would expect children who begin intervention younger to respond more rapidly as opposed to children who begin older and are higher up on that severity scale. Although it's challenging to give exact time frames due to all of the contextual factors, some of which are related to age, but others are not. So thinking about the carryover at home, and there would be a huge difference in expectation if you're dealing with a family who has really great carryover as opposed to an inconsistently carried over home program. But generally speaking, if you don't begin to see resolution of asymmetries between 4 to 6 weeks, after 4 to 6 weeks of therapy and home carryover, then you need to start thinking about being a little bit more aggressive and making a referral back to the physician. So they may be a candidate for Botox or perhaps even surgical intervention. But again, that 4 to 6 weeks is kind of a loose time frame because we would expect it to take longer than that if the child began therapy older and is higher on that severity level. After about 6 months of intervention, if you start to see that the child is no longer making any gains, so they've somewhat plateaued, but yet they're still asymmetrical, that's going to be another consideration to refer back to the physician if they need to continue to make improvements, but they're not. So maybe they need an additional step to get them the rest of the way. So that would be important consideration when looking to reassess these children. Looking to conclude an episode of care for a child with torticollis should happen when the below 5 criteria have been met. So you want passive range of motion to be within measurement error or within 5 degrees of the involved side. You want the active movement to be symmetrical between sides. The child should be developing in an age-appropriate trajectory, so there's no evidence of any gross motor delay at that time. There's no head tilt, and the parents and caregivers have been educated and they understand that they need to continue to monitor this as the child grows and develops. As a child begins to gain more skill in higher level positions, so let's say the child is discharged at 6 months of age, and then they begin within the next several months to pull to stand and start cruising. It's not uncommon for these children to relapse or reposition into these tightened postures as they're trying to gain skill against higher levels and move against gravity. So you want the caregiver to be aware of that potential concern and to be continually monitoring for that so that the therapist can become involved again if need be. You want to reevaluate this child on a consultation level. Usually when the child begins walking, depending on when you discharge them, that time frame would vary to assess for that potential for reoccurrence. So giving the parent the information that that could continue to happen and making sure that they have the skills to carry out all of the previous aspects of the home program related to positioning and all of those other pieces that we've already talked about would be critical before thinking about discontinuing the child.